Hello, everyone. I hope that you're doing well. My name's Daniel Williams. Thank you for joining me today. Today, we're going to go over a section of the detailed content outline for the therapist multiple choice exam. It'll also match up with a detailed content outline for the clinical simulation exam. Specifically, I'm going to be in the section on performing clinical assessment, and I'm going to try to strive to discuss pneumothorax as well. So, clinical assessment, super important. The assessment skills are going to make or break you as a respiratory therapist. So good, solid clinical assessment and attention to detail is going to be what you need to do as a respiratory therapist. You'll learn that through practice, your assessment skills are going to get better, your attention to detail is going to get much better, and that's going to serve you well in your career as a respiratory therapist. And who knows, you may even find that you're assessing things all over the place, whether it's out of the hospital, what have you. Personal story of mine that I can share is with watching the Lone Survivor when that movie came out with Mark Wahlberg in it. Um, I recall they're carrying him away. The opening credit or the opening scene, opening credits are he's being carried away on a helicopter, and in this helicopter they've provided supplemental oxygenation via non-rebreather mat. But if you pay attention, that reservoir bag does not have any flow going to it whatsoever. You and I know that that bag is supposed to be fully inflated, and if it is collapsing upon inhalation, that we should increase the flow to that bag so that it doesn't collapse upon inhalation, so that the patient's getting the most amount of oxygen when they breathe in. So not just in the hospital, but assessment and attention to detail tends to pay dividends, and you'll find yourself paying attention to it elsewhere. But nonetheless, let's get back to the TMC content outline, and we'll tend to focus on treatment of a pneumothorax. What is a pneumothorax? A pneumothorax is when you've got free air that collects in the pleural space. Okay, what does that mean? So when it's collected in the pleural space, you've got a visceral pleura and you have a parietal pleura. The visceral pleura is the lining of the lung itself, and the parietal pleura is the lining of the inside of the chest wall. Every time we breathe, you can imagine those items are gliding over each other. So there's a little bit of a serous fluid in there that provides some lubrication so that you're not causing any type of inflammation or anything of that nature. But ultimately, those two surfaces should, for the most part, stick with each other and not ever really be significantly separated. There are some things that can cause significant separation, whether it's the onset of a pleural effusion, pneumothorax, hydrothorax, chylothorax, and so on and so on. Typically, the prefix to those words will let you know what the substance is that's collected in the pleural space. So, in the case of a pneumothorax, it's free air in that pleural space. If it's a hydrothorax, it's fluid. Chylothorax, it's chyle in there. Hemothorax, it's probably blood and a combination of other fluids, and you could also have a pleural effusion. So, in addition to your assessment skills, you're going to be taking 160 question exam, while 20 of those are test items, while 140 of those are scored for you. There are some test and nuggets that the MBRC will throw you away. I tend to tell all of my students that the MBRC will throw you a bone if you'll let them. So if you'll pay attention to the way in which the questions are worded or some of the verbiage in the question stem, then that can kind of clue you in on as to what you should be looking for. For instance, in the case of a pneumothorax, there's a few different things that we want to make sure that we mention right off the bat. Whether it's an adult patient you're taking care of or a neonatal patient you're taking care of, you need to make sure that you can pick up on some of those common themes that the NBRC might utilize when they're testing. So, for instance, if we're in neonatal world and we're breaking out the transillumination of the chest, if you're transilluminating, there's a decent chance that a pneumothorax is going to be involved, because with that you can visibly see that. If you're performing an ultrasound with an ultrasound of the chest and you've got this barcode sign that shows up, that's indicative of a pneumothorax. If you're doing a physical assessment on a patient, you've got absent breath sounds, deviated trachea away from the affected side or away from the absent breath sounds, that's decent indication that there's a pneumothorax. You may also have a situation where you're performing diagnostic percussion, where you're striking the distal interphalangeal joint and you're hearing those hyperresonant or even potentially tympanic tones. It's going to be over the course of a pneumothorax. You may see some verbiage that says the patient's having paradoxical movement of the chest. that tends to go along with the flail chest. And with a flail chest, there is a potential for pneumothorax. Flail chest, you've got double breaks on adjacent ribs. And then that causes the chest to essentially move the opposite of the way in which we would think that it should. So we know that when we breathe in, chest should rise. When we breathe out, chest should fall. So you also understand the normal mechanics of ventilation. When the diaphragm contracts, it creates a vacuum, if you will, inside of the chest that drops the pressure inside of the chest because in order for flow to occur, you've got to have a pressure gradient. So when that pressure inside of the chest drops, it allows flow from the atmosphere to go into the lungs. Then eventually those pressures at the airway opening pressure and the pressure inside of your lungs are going to equilibrate. They equilibrate. You've got the elastic recoil forces of the lung because the lungs always want to recoil inward as opposed to where the ribs always want to go outward. So those two forces tend to oppose ventilation as well. But the elastic recoil forces of the lung, you've also got surface tension that will play a role in that, but we're not going to focus on that terribly much right now just because we've got a short bit of time and we want to get to talking a little bit more about a pneumothorax. Uh, when the elastic recoil forces kind of take it increases the pressure inside of the chest. So pressure is now greater in the chest than it is out of the mouth. Our airway opening pressure, that's going to facilitate or that's the pressure gradient we need for flow to come out of the mouth. So with that being said, your visceral and parietal pleura should pretty much always be in contact with each other, and we can have a separation of that. Free collection of free air in that pleural space, and that is a pneumothorax. You can have an open pneumothorax, you can have a closed pneumothorax. Open pneumothorax is tended going to be caused by some type of penetrating chest wound, whether it's gunshot, stabbed, they've been impaled by some means or what have you. Your chest, the inside of your chest is now open to atmospheric air. We'll focus on the closed chest wound here in just a little bit because I'm going to kind of get geared toward treatment of the tension pneumothorax here in just a moment or so. But if you've got a closed chest wound, uh, that becomes really problematic because you're going to have constant air leaking out into the chest cavity or that pleural space, and the pressure cannot escape out of the chest. So all that pressure is going to begin to go inward. When that pressure goes inward, it's going to start to shift organs in the chest or your mediastinum. Remember, from pathophysiology, you've got disease processes that will push the trachea away from the affected side. We have disease processes that will pull the trachea to the affected side. A pneumothorax tumor or blood or fluid in the pleural space will push away from the affected side. Pneumonia, atelectasis consolidation will pull toward the affected side. So those are going to be some things you want to make sure you pay attention to and pick up on too if there's tracheal deviation. Uh, you're going to notice an onset of difficulty breathing, shortness of breath. You may notice tracheal deviation. There's going to be heart rate changes, blood pressure changes. So you want to be in tune to that with your assessment skills. Do all pneumothoraces need to be evacuated via chest tube or needle decompression? No. There are some pneumothoraces that can resolve on their own, and the body will kind of fix it and go on. You also have a certain patient population that is more prone to the onset or the development of what's called a spontaneous pneumothorax. That's another MBRC test and nugget for you there as well. So your really tall, thin, slender individuals tend to be at a little bit greater risk for the onset of a spontaneous pneumothorax. When do we need to evacuate the free air out of the pleural space? Typically, when it gets greater than 20 to 25% of that lung volume or the patient becomes symptomatic, that's when we're going to look at evacuating. And like I said, under general circumstances, may call the physician. We're going to support the patient until the physician gets there, the surgeon gets there to be able to place the chest tube. And in some cases, you may be there to assist with that overall procedure as well, too. But what I want to talk about is the tension pneumothorax. So you've got inside of the chest cavity, we've got two lungs there, but situated in between those lungs, you've got a pretty important organ, the heart. The heart, you've got the right side, the left side. The right side of the heart pumps blood into your pulmonary circuit. The left side of the heart pumps blood out to your systemic circuit. And we need that heart to be able to pump blood effectively so that we can send blood through that pulmonary circuit so that it can do gas exchange, pick up oxygen, drop off CO2, and maintain that homeostasis that we like with our acid-base balance and oxygenation because our body likes oxygen. Then we need the left side to function so they can pump all that freshly oxygenated blood out to the rest of the body, and it can meet the metabolic needs of the body. So if the heart, if you get a pneumothorax and it becomes under tension, that air begins to collect in the chest cavity and it's going to squeeze down on the heart and cause a tamponade effect. Well, those atria and ventricles cannot accept as much blood volume. So the preload is going to go down significantly. Because the preload goes down, the cardiac output is going to be problematic as well. So it's going to pretty much go zero. So systemically, your blood pressure is going to drop. That's a life-threatening situation, and we must be able to pick up on that and have the corrective action with that as well. So if you come upon tension pneumothorax, uh, what you're going to do is you're going to first be 100% certain that there is a tension pneumothorax and that you've got to act immediately. And by immediately, we're going to do needle decompression with the 14 gauge angiocath. So let's assume that the patient has a pneumothorax on the right side of their chest. Your palpation is going to come in handy here because you're going to have to find the second intercostal space in the midclavicular line. So find the clavicle, anatomical landmark, midclavicular line. You're going to palpate for the suprasternal notch, palpate for that's the little V area right there in your neck. Suprasternal notch, you'll come down over the outward protrusion where the manubrium meets the sternal body, and that's going to put you directly over rib number 2. So rib above that is rib 1, rib below that is rib 3. So if my fingers are representative of rib 1, rib 2, and rib 3, this is our first intercostal space. The space in between rib 2 and 3 is our second intercostal space. That's the sweet spot where we want to stick this needle perpendicularly to through the skin until we hear a rush of air come out. So what we're going to do is palpate midclavicular line. We're going to get into that space and we're going to push the needle through. Now, can we just willy-nilly go wherever we want to and shove that needle in? No. You want to make sure that you're pushing just over the top of the bottom rib or rib 3 as opposed to just under rib 2 because the costal groove is underneath those ribs. And in that costal groove, you got blood vessels and nerves. So you stand a better chance of nicking a blood vessel and or nerve if you're sticking just underneath the top rib as opposed to over the top of the bottom rib. So that's going to be important. And you'll hold that catheter in place until the physician or the surgeon gets there to insert a chest tube. You may even need to put a 3-way stopcock on there so that you can control, evacuate the air and allow that air to go in. So looking at this chest x-ray, I don't want to show a chest x-ray and not ever say anything about it. So this individual, if you look, it's oriented appropriately, and you'll notice you lose your vascular markings here. So his vascular markings should extend all the way out to the chest wall. The vascular markings stop here, and we've got an increase in hyperlucency or radiolucency. Those are terms that we'll hear with radiographic examination and with clinical assessment or performing clinical assessment. Radiographic examination is a part of what you need to be able to do and study for your board exam. So this increase in hyperlucency or radiolucency is an increase in black space that we see there. Because with chest x-rays, you'll have things that show up various shades of gray or white, maybe not quite 50 shades of gray, but uh, bone tissues, things like that will show up either white, radiopaque, or what have you. That's a term that you'll have. And then air-filled spaces are going to show up darker or more radiolucent. So this increase in radiolucency lets us know that we do have, in this case, a pneumothorax on the patient's right side, and we do not see the insertion of or chest tube inserted or anything of that nature. So to piggyback on the needle decompression, if you'd like to have a better visual than me, uh, you know, touching all over myself or what have you, if you get a chance, go to YouTube, the movie Three Kings. It's got Ice Cube, Mark Wahlberg, and George Clooney in it. George Clooney gets to channel his former ER days a little bit in this. Mark Wahlberg ends up, his character gets shot, and Hollywood does a pretty good job. Hollywood flubs up a little bit every once in a while, but they do a pretty good job with this needle decompression scene that they have in there. So he gets shot in the chest, and they're gonna needle decompress that because it goes in, it shows the lung collapsing. But it's like I said, Ice Cube, Mark Wahlberg, George Clooney are in that movie, Three Kings, needle decompression. It's about a couple 2 to 3 minute clip, and there is some rough language in it. So if you're sensitive to that, be mindful of that. But Hollywood does a pretty good job of depicting that. Questions, comments, concerns? Thank you all for your time and attention. I hope you learned something. I hope you're a little bit more prepared for the TMC. You all have a great day.